Hello people. So we are looking at top priority questions from obstetrics with the answers we are looking. We have finished this much, right? Now we will move on to this side, MTP, medical termination of pregnancy, and then we will look at everything about delivery, all mechanisms of delivery, everything we look at. And after that we have to look at specific terms in obstetrics. Okay, this entire thing we should look at so that we will be able to pass obstetrics. Okay, so now let's get started with MTP. MTP means what, people? Medical termination of pregnancy. So basically there are some indications for it when there is a fetal abnormality, or if there is a threat to mother's life, right, etc. So you will have to look at all those recommendations. If it is a product of rape, etc., all that you will have to look at. So do you know, people, that there is an amendment in 2021, so you should know this. So what are the changes that they made? No, even unmarried women can get MTP. Okay, and then rape survivors up to 24 weeks they can get it done. Beyond 24 weeks, if there is fetal abnormality, they can get it done. Earlier, it was required that you need 2 medical practitioners after a certain week. Now what it is 1 registered medical practitioner till 20 weeks. Are you able to see? 1 registered medical practitioner till 20 weeks. 2 registered medical practitioners from 20 to 24 weeks is the need. Okay, so just 1 doctor can give you an abortion, that is do you say abortion? No, medical termination of pregnancy up to 20 weeks. Okay, that is almost like 4-5 months, is it? So you will be able to terminate the pregnancy up to 20 weeks with the help of 1 doctor. Okay, 1 registered medical practitioner. Okay, then what is the fine? If somebody breaches the women's confidentiality, up to 1 year of prison and fine also they'll put. I can't believe that we were living in a world where it applies only to married women. What nonsense. Now let's move on to delivery of the baby. Let's look at the normal mechanism of labor, everything. Okay, first let's start with non-stress test, CardioTopoGraphy. So non-stress test means what? You've seen this, right? This is non-stress test where you're not giving any stress to the baby. You're just monitoring its heart rate. So you can see the heart rate is having beat to beat variability. Normal heart rate is what? 110 to 160, is it? So here you can see beat to beat variability, and there should be 2 accelerations in 20 minutes. At least 2 accelerations, and these accelerations should be 15 beats, at least increase should be there, and it should last for 15 seconds. Okay, everything is 15, 15, 15. So remember all that. And here they have put the fetal movement because this is a non-stress test. There is nothing to do with uterine contractility. Okay, but when you add uterine contractions here, it will become what? CardioTopoGraphy. So this is cardiac part and this is the topo part. So CardioTopoGraphy it will become. If there is no topo part, it will become non-stress test where you're monitoring only the fetal heart rate. So you understood there should be 2 accelerations. Use a green, please. There should be 2 accelerations where there is increase of 15 beats, and that increase should last for 15 seconds. Remember, okay? 2 accelerations, at least 2 accelerations in 20 minutes. This is a reactive non-stress test, which is good. Okay. Okay, where are we? Non-stress test we looked at. We looked at they have marked it along with the fetal movement. Very good. Then this is a non-reactive. You can see it is so flat, and beat to beat variability is also very less. Not good. Not reactive is not good. This is having decelerations, is it? Decelerations are really, really bad. Okay. And something like late deceleration, early decelerations and all will come with respect to the uterine contraction. Okay, late deceleration is very bad. So this is the biophysical profile. Very important, they'll ask you biophysical profile. Non-stress test, fetal breathing, fetal movement, fetal tone, amniotic fluid index. But modified biophysical profile will have only 2 things. That is the non-stress test and the amniotic fluid volume. What are the other things? The fetal breathing, movement, tone. Okay, breathing, movement, tone is not there in the modified. Okay. So this is the biophysical profile. So they are saying that if it is 10 means it is very good. Okay. That is, it's higher, it is good. Lower is bad. So what is the biophysical profile? Non-stress test, amniotic fluid, fetal breathing, movement, muscle tone. Okay. But there is modified biophysical profile where you are using only what? The NST and the amniotic fluid index. Okay. So what are the biophysical tests if somebody asks you? The movement you will count, ultrasonography, CardioTopoGraphy, non-stress test, biophysical profile, Doppler ultrasound, vibroacoustic stimulation test, that is if the baby doesn't move much. Then contraction stress test, that is oxytocin challenge test. This is a stress test. Remember, stress test means you are giving oxytocin. Okay. What we are talking about in this video is non-stress test. Correct? Non-stress test means you are not giving any oxytocin. Did you understand, or it became too much? See, if the baby doesn't move much, they're giving vibroacoustic stimulation. Okay. Now let's talk about induction of labor. Yay, people, something is going into your head, no? Will you be able to pass, people? Okay, let's now look at induction of labor. Induction of labor, IOL. Why does this sound like intraocular lens? Okay. So when will you induce labor? You want to have, before the spontaneous onset of labor, you want to induce her. Okay, that means you want to initiate the uterine contractions. Why? You want to end the pregnancy. Mainly, what will be the cause? Eclampsia. Okay, eclampsia or diabetes mellitus, because you don't want to wait because sudden death of baby can happen, or if there's abruptio placentae, or if it is post-maturity, baby has post-maturity and it's still not coming out, right? All these are common indications of induction of labor. Very good, people. Then, what are we looking at? Contraindications. Contraindications means anything that is saying that she should not deliver vaginally, that will become a contraindication. That means if it is a contracted pelvis or a cephalopelvic disproportion, or there's a malpresentation, or there's a previous classical cesarean section, right? Or if there is mother's heart disease, then you don't want her to push the baby, right? So all these will become contraindications. Okay. Then, so the Bishop score should be greater than 6, some say 9. So basically you should, what is Bishop score? Bishop score is this one. The cervix should be dilated, effaced, the consistency should be what? Soft, yes. Position of where should be the cervix? Anterior. The station of the head of the baby, it should be -1 or 0. -1 or 0. Okay, spines is 0. So it should have come at least till here. That means you can induce the labor. Okay, if it is a Bishop score is good, then only you will induce the labor. Okay, so what and all you will do? So you are putting Foley's catheter so that she will get the pain, is it? Or you can put laminaria tent so that you can dilate the cervix, right? Now, what is the induction of labor? You will give prostaglandin, dinoprostol gel, misoprostol, oxytocin, mifepristone. See, oxytocin you will tell, no, you want to initiate contractions, yes. Surgical also you can do artificial rupture of membranes, stripping of membranes, or you can combine medical and surgical. Is anything understandable? What are we looking at? Induction of labor. Very good. So you have medical methods and surgical methods. In surgical you have rupture of membrane. Very good. Very good. Very good. So this is the scheme of induction of labor. Okay. Cervix should be favorable. Remember, if cervix is favorable only, then you will do amniotomy and oxytocin they are giving. If cervix is unfavorable, you will try to make it favorable and then you will continue. Okay. Good, people. Now let us move on to mechanism of normal labor. This is the most important thing in the whole of obstetrics. If you understand mechanism of normal labor, that means the mechanism in which a baby comes out by itself. Okay, that is mechanism of normal labor. Okay, people. So look at this mechanism of labor. Okay, normal. So look at this. So this is left occipito-anterior, which is the most common position. What do you mean by left occipito-anterior? So this is the maternal pelvis. So in maternal pelvis, the baby's occiput will be here. Okay. So this is left occipito-anterior. So occiput is here. So here is the eyes, right? Eyes will be here. So this is occiput, left occipito-anterior. Okay. This is the most common. Look at this baby's occiput. Where is it? Left of the mother and anterior. Okay. Left occipito-anterior. You can remember like this. So now this baby has to come out. Okay. How will it come out? All the time it is descending. Okay. All the time descent is happening. Okay. The head will engage. First thing that will happen is engagement of the head. Once the head engages, then again descent will continue. Then internal flexion. See, the baby is flexing. Internal flexion happens. Okay. Then after flexion, what will it do? Let's go and look at the steps here. Look at the mechanism of normal labor. Here they have actually written here, engagement, increasing flexion, internal rotation. So the internal rotation happens. What do you mean by the internal rotation? It becomes occipito-anterior. That much you remember. What happens? It becomes occipito-anterior. So whatever is there here, it has rotated. So 1/8 or how much it has to rotate, it will rotate. Okay, it will become occipito-anterior. That much you remember. Shoulder, half of whatever it turns, it is turning. Okay, that much you can remember. Head is turning and it is becoming occipito-anterior. Now after that, come here, occipito-anterior. Guys, do you know where we are? We are in this step. See here, internal rotation will occur. It will become occipito-anterior and shoulder also will rotate. Okay, then crowning. Crowning means what will happen once the head you can see, it will not go back. Okay, with further contractions, etc. That is crowning. Okay. Okay, crowning done. Then a delivery of head by extension. So now the head of the baby will deliver by extension. What did you understand by this? Did you understand anything? See here. Baby's head is flexed, correct. Then what will happen? the occiput has become anterior. Okay. So now the baby's occiput is here. From here it has come here. The occiput is here. Now whatever flexed head is there, it will extend and the head will come out. This is more better seen in the 3D model. Okay. So the head, see now flexed head. Make head, flex your head, people. Come on, all of you flex your head now. Extend your head. Yeah. And you're coming out. Okay. The head is coming out from the pubic symphysis. You can, from the below that. Okay. The head is delivered by extension. Remember, head is delivered by extension. Now coming to restitution. What do you mean by restitution? Restitution means it will, whatever internal rotation happened, it will go back. Okay, that is restitution. Then external rotation. Then further little more it will rotate. That will become external rotation. The restitution is only correction of the internal rotation. And then furthermore it will rotate in the same direction. That is called as external rotation. And then the delivery of the shoulder and trunk by lateral flexion. Shoulder delivery how? By lateral flexion. Okay, let's look at the images. What are you seeing in this image? It's descending, it's engaging, right? And then there is some internal flexion, is it? Now what you're seeing here? Rotation, internal rotation, crowning, delivery of the head by extension. Okay? So did you get it? What are the steps that you looked at? Engagement, descent, increasing flexion, internal rotation, crowning, delivery of the head by extension. After that, restitution, external rotation. Okay? And then delivery of the shoulder and trunk. This is very important. Good people, second stage of labor over. Now third stage of labor, what will happen? Placental separation has to happen. Baby has come out, placenta has to separate, then separation of membranes, expulsion of placenta has to happen. So active management of third stage of labor, they will ask. What will they ask in the exam? Active management of third stage of labor. That means, you know what you'll do once the baby is out. So you will give her oxytocin, okay, so that the uterus will contract and there'll be less PPH. And there will be, you have to do massage the uterus and do controlled contraction, etc. Okay, so you'll have to observe her, monitor vitals, etc. So this is the active management of third stage labor. It will reduce the maternal mortality in a great amount because you can control PPH. What is PPH? Postpartum hemorrhage. Very good. Now let's move on to this episiotomy. When do you do episiotomy? Just before the crowning, okay? Crowning, that is when you do episiotomy. Episiotomy is a planned incision on the perineum. See here, it is a planned surgical incision on the perineum and the posterior vaginal wall, okay? So here they are showing how they are doing episiotomy. It is medial-lateral, okay? So medial-lateral means neither medial nor lateral. That means what to say? If you say this is medial and this is lateral, they are doing medial-lateral here. Why won't they do medial? Because if you do medial, it will go and touch the anus and that's very bad. If you do lateral, what will happen? You will touch the Bartholin glands. They don't like. So medial-lateral is what they follow. Okay. So medial-lateral, what am I talking about? Episiotomy. Why will you do this? You will enlarge the vaginal opening, you will minimize the overstretching and rupture of the muscles. Advantages to the mother is that it is a controlled incision is better than something that is uncontrolled, right? And there is reduction of trauma and there is reduction of prolapse, etc. and urinary incontinence. For fetus, it will reduce the intracranial injuries, and even in the after coming the head of breech, you can use this. Basically, remember, for vacuum and forceps, if you are using, you have to do episiotomy. When will you do it? Rigid perineum, if it is a rigid perineum, if there is you are anticipating perineal tear, if it's a big baby, etc. If you're doing forceps, ventos, are you looking where you are looking? Forceps, ventos and all, if it is there, you have to do episiotomy. If previously this lady had a pelvic floor repair, you definitely don't want to tear it anymore, so you'll give episiotomy. So basically, when will you give? When there is threatened perineal injury, like in a big baby, face to pubis delivery, breech delivery, shoulder dystocia. If there is a rigid perineum, if there is occipito posterior or face delivery, that time also they're doing. If there is forceps and vacuum also you're using. When will you do it? At the height of contraction, just prior to the crowning, okay? Why will you do it at the height of contraction? Because that time the perineum will be thin, okay? The best one is which one? If you don't touch the anus, the median is actually the best, because you don't even cut muscles in the median. But it's very dangerous, you cannot extend it and you might injure the anus, so that is really risky. So that's why they do mediolateral. They use this type of episiotomy scissors. Just remember it as episiotomy scissors. Okay. So what are the structures cut? See, it's a scissors, so you're cutting from two sides, right? From inside you're cutting the posterior vaginal wall, correct? And on top you're cutting the skin, correct? So you're cutting the posterior vaginal wall inside and then the skin from one side. In between these two, what will you cut? Some muscles should get cut, isn't it? And then the fascia surrounding the muscles. So let me put it like this. From inside, that is posterior vaginal wall, you're cutting. From outside, you're cutting the skin and subcutaneous tissue. And then there are some muscles in the middle. That muscles fascia you will cut from both the sides, and then the muscles you will cut. Which are the muscles? Superficial and deep transverse perineal muscles, bulbospongiosus, and part of levator ani. These are the muscles. Which are the muscles? Come on, focus. Levator ani, very good. Perineal muscles, bulbospongiosus, some muscles you will write. And then some nerves and vessels also you write off. Okay. Did you get it? So what and all you will cut? Tell. From inside the posterior vaginal wall, very good. From outside the skin and subcutaneous tissue, middle some muscles will get cut. Both fascias from both sides will get cut of these muscles. Yes. Which are the muscles which are getting cut? The levator ani, part of levator ani, some perineal muscles, and some that's it, right? Bulbospongiosus, very good. And then some vessels and nerves also will get cut. Very good, very good. And how will you repair it? The steps of episiotomy repair they have shown here. So 3 steps, is it? 3 steps. So first you will inside the posterior vaginal wall, that mucosa you have covered. Then muscles they have sutured, and then only the skin they have closed. Okay. So this is how they are doing the episiotomy repair. It's written here. See vaginal mucosa you will stitch, and submucosa, then the perineal muscles, and then the skin and subcutaneous tissue. Okay. This is the repair. And what sutures you will use? Interrupted sutures. These people know simply in the Viva and all, they'll ask you what are the complications of episiotomy and all. Just remember some dyspareunia, very remote to pain during intercourse, right? Then some scar can be there, scar endometriosis they are saying. Then some perineal lacerations in subsequent labor, that's what they are saying. All very rare. Immediate and all, what and all, you will have hematoma, pain, all that you write, okay? Injury to rectum, standard things that you will write. Now we have to move on to vacuum versus forceps, right? Okay, so what are we going to read now? Ventouse versus forceps. So, breathe in, breathe out. Ventouse versus forceps. Ventouse means vacuum. Vacuum spelling is UU, okay? V-A-C-U-U-M, okay? Vacuum. Even in our question paper, they gave the spelling wrong. V-A-C-U-U-M, okay? Vacuum. Now, vacuum, the best thing is, it will take less space. No, so it is very good for mother. Who is happy in this? Mother. Mother is happy in vacuum. Okay. Who is very happy in forceps? Forceps, baby is happy because you are holding it correctly and pulling it. Okay. So, baby is happy with forceps. Mother is not at all happy with forceps. Why? Because you have to insert left, right. So much of space occupation, so space occupying, yeah. Trauma for the mother, very high. In what? In forceps. Now, what does the baby like? Baby likes forceps. Baby likes forceps. Who likes ventouse? Mom likes ventouse. Mom likes vacuum. Okay. So this is what you have to understand. Now, in ventouse, what happens to the baby? It can form a chignon, kind of a pulled kind of a head, right? So you have to write all that. Okay. Now, basically, forceps, there are many varieties of forceps. Okay. You have the long forceps, short forceps, and then you have the outlet forceps, high, level, low, is it? All those forceps are there. And forceps has left and right, you have to join them. So some training is required for forceps. However, vacuum, training is less. Even a midwife can use it. But the problem with the vacuum is, it takes time for the pressure to build, and then you have to release the pressure also very gently. Okay, you cannot suddenly give pressure and pull and suddenly release the pressure. No, that doesn't work. So ventouse takes time because you have to build the pressure in vacuum, so it will take time. Okay. So that's all about forceps ventouse. If you have understood this much, it's enough. Okay. So what did we tell you? Vacuum good for home, mother. Forceps good for home, baby. Okay. Partogram. Now let's go to partogram. So in partogram, you are monitoring the progress of labor, right? So in this, you have what and all information. You have the mother's information. Then you will monitor the fetal heart rate, and then you will monitor. Let's zoom a little. Yeah. Fetal heart rate they have written here, and then what type of amniotic fluid. Then here they have shown the cervix, X mark they are using for cervix, and then descent of head. So basic cervix, how much is it dilated? Where is the station of the head? Right? Then there's an alert line and action line. What do you mean by alert line? Alert line means if it touches here, then you have to be careful. Before it reaches action line, she has to reach the place where they can handle all this. Okay? So that is what is alert line. Then after 4 centimeter of dilatation only, it is active phase of labor, right? Till then it is latent phase. Then you have contractions. How many contractions? All that you will mark here. Then oxytocin, how much you have given, what are the drops. Then drugs that you are given, that you will write here, same thing. Then pulse you will put in dot, you will mark here. Blood pressure with this type of thing. Can you see here? Blood pressure up and down, upper limit and lower limit, systolic and diastolic they will mark here of the mother, okay, of the mother. Then they are monitoring her temperature also and urine output, okay. So this and all they are monitoring. So did you understand Pathograph? It's very interesting actually. Pathograph is very easy also. A very important question in the exam. You can draw this and get very nice marks, okay. Practice it, sit and practice this. It is actually very easy. See, look at this one which has been marked also. So here you can see fetal heart rate they have shown here. Then amniotic fluid is clear they are saying. Then alert line, action line, where is it? X mark for how much of cervix has dilated. Descent, see the baby's head is going on, coming down. So it is descent. Here contractions they have shown here in full dark. Then here they have shown, see pulse they have marked in dot and blood pressure they have marked in that up and down. That is that upper limit and lower limit. Temperature they have shown 36, 37. And urine output they have shown. So easy, right? How much protein is there in urine, volume of urine, etc. Super people. Now we'll go to breech. What do you mean by breech, people? Are you able to see anything? Yeah. Good. So it is loaded now. So look at breech. Breech means the podalic pole is there here at the outlet, right? So you can see here that this middle one is complete breech. That is totally flexed. Everything is flexed in this baby. Okay, this is a complete breech. Okay, flexed. Now what you're seeing first is the frank breech. Frank breech is where the legs are knees. Yeah, they are extended. Okay. So extended legs, this is frank breech. Why? This is more in primigravida because she has very little space. No, the baby has totally, it will be like this. You cannot do any version in this. You cannot turn the baby because it is a very small uterus, right? For primigravida. So this you will see where in the primigravida. What is this breech called as frank? Just remember Frank is kissing his leg kind of a thing. Okay. Frank is kissing what? Frank is kissing his feet. Yeah. Yeah, feet. So this is frank breech. Okay. This will engage very nicely. Why? Because this is so round and nice. No, engagement will happen. Then you will have to do pinard maneuver to make sure that this guy flexes his leg. Okay. Now coming to the middle one, complete breech. Complete breech, guys, is flexed. It's completely flexed. But here what and all is trying to come out? Two buttocks are trying to come out. Two feet are trying to come out. One genitalia also trying to come out. Everything trying to come out here. Yeah. But in this, the thing is, anyways, it is not in primigravida, no? So you can turn this guy. So you can do external cephalic version. What is this? You can do external cephalic version by putting pressure on, just maneuvering on the mother's abdomen. You can turn the baby. And then it will go into cephalic presentation. You can deliver like that. Okay, that is the best thing about this flexed one. Okay, then coming to the last one, footling presentation. Footling presentation, you can see the legs are, the thigh is extended and the legs are partially flexed. Okay. So this is footling presentation. They won't ask this in the exam. Then you have knee presentation also. Okay. In which one can you do version? External cephalic version. Which one can you do? In this one. External cephalic version, because it is a multi-parous woman. You can do external cephalic version in this. Okay. Good. Which one will engage? Frank breech will engage. See, breech delivery mechanism of labor means mechanism of labor whenever they means naturally how will it come out? That means without any doctor's assistance. That means first the buttocks have to come out, then the shoulder will come out and then the head will come out. Okay, this you have to look at in detail in our video. So breech delivery mechanism of labor means what? Natural. Without assistance, how will it come? Now coming to assisted breech delivery. Assisted breech delivery means you are going to assist the breech delivery. See, you tried to do cephalic version, everything that didn't work. Now breech only is coming out. Now what will you do? Okay, so you need skilled obstetrician, anesthetics, you need an assistant who's always putting pressure on the mother's abdomen, all that you need instruments also. So what and all you will do here? No, if it is frank breech, hold on. If it is frank breech, okay, look at this. So you will first have to wait for the buttocks, okay, to come out. Then they are doing this pinard maneuver. Pinard maneuver. So pinard maneuver is where they are trying to get the flex the extended legs. Okay, they will tap on the popliteal fossa and it will flex and it will come out. Okay, this is pinard maneuver. Then you have what is called as after the buttocks, what will have to come out? Shoulder. So Forceps maneuver you have in that. See, they're turning the baby. So the posterior is coming front. I mean, this shoulder, they should not say posterior, but anyways, posterior shoulder now is coming anterior and it's getting delivered. This is the Forceps maneuver, okay? And they are showing how the other shoulder is delivered. So this is the Forceps maneuver. Then, now we are in breech. So buttocks came out, then shoulder came out, next head. After coming head of breech, okay? After coming head of breech, how you will deliver means you should tell three things, okay? One thing you will say is, go here. Yeah. After coming head of breech, there are many ways. You have burn, Marshall technique. Okay. Technique. What is spelling of technique? N-I-Q-E, is it? Yeah. Technique. Then you have MSV. Technique. Then you have Piper Forceps. Piper Forceps also you can use. We'll show you all this. Okay, hold on. These are the three things. Burn Marshall technique, MSV and Piper Forceps. QUE. Sorry, QUE. After coming head of breech, you can see they're letting it hang, right, until you see the nape of neck. Pressure by assistant is always there. Always you write pressure by assistant on the abdomen of the mother. See here? Pressure by assistant. Pressure, this is there in almost everything, right, in breech, okay. Then you can see continuation of Burn Marshall technique. They're turning the baby like this onto and swinging it like onto the mother's belly, and the head is borne by extension only, right, in this also. Over, one method over. Burn Marshall over. Next is what? MSV. MSV, look at this MSV. Morrissey Smelly Wheat. Earlier they were putting the finger in the mouth, is it? Now they are actually touching the malar flexion, shoulder traction, okay. So this is Morrissey Smelly Wheat. Delivery of after coming head by forceps. This is the Piper Forceps they are using, okay. So assisted breech delivery we have covered. So many names are there. Pinard maneuver, Lowset maneuver, Burn Marshall technique, Morrissey Smelly Wheat, Piper Forceps, everything we have written. I don't know if we missed anything, but this much about breech if you write should be enough. Okay, now let's get back to our list. Last one guys, lower segment cesarean section. Lower segment means what? The lower segment of the uterus, not the abdomen, remember. So lower segment we were referring to the uterus. On abdomen what will you do? Fan and steel incision. 3 cm above pubic symphysis, it's a transverse incision like this, something almost transverse. This is fan and steel incision. In this, the main thing you have to remember is we will not cut the rectus sheath, we will only separate it, okay. So, what is good about this? It is going to be invisible, right? The mother can wear nice dress also. So, cosmetic value will be there, and then there is a less chance of wound dehiscence, etc. Okay. Then, incision and hernia chances also less. Uterine incision is lower segment. That's what you have to understand here. So what you're seeing here, lower segment of the uterus, you will do uterine incision. Now once you enter after the abdominal incision, lower segment of the uterus, again you can do transverse or longitudinal, or you can do J shape. But you have to do on the lower segment. Nobody does on the upper segment. Upper segment if you do, that is a classical one like this, okay. This they will do very rarely, okay. And sometimes just to bring the baby out in a dying mother or a dead mother, something like that. That's what the textbook says, okay. Now you remember only lower segment cesarean section. Why do we do lower segment cesarean section incision on the uterus? Because the lower segment will not contract and relax like the upper segment, okay. So that is why it can next delivery there will be less scar rupture, etc. That's why lower segment cesarean section is done. Membranes ruptured if intact, and then you will deliver the baby's head. How will that baby's head come out? With flexion, okay. And you're using your hand as the fulcrum. So this is all some physics here, okay. So head is coming out of the baby. And whenever the baby is coming out, the Doyen's retractor they will remove, okay. Then only the baby will come out. Then you are delivering the trunk. How will the trunk come out? See how happily and smilily it is coming out. Trunk will come out and then the baby. Then you have to introduce the retractor again. Then placenta and membranes are coming out, okay. Then how will you stitch it back? That's what you should say, right? You will, the uterine incision is sutured in 3 layers. Uterine incision is sutured in 3 layers. Which are the 3 layers? First layer is, see here, first layer is deep, then superficial, then the peritoneum, right? Yeah. So you have to learn what type of sutures are they talking about. They are using chromic catgut or vicryl, okay. So this is absorbable, isn't it? Okay, so then what should you? You'll close the abdomen in layers, okay. Little post-operative care, management, monitoring vitals, scar, everything you write, okay. So we're done with all these high priority topics, okay. Next, we have to look at the specific terms in obstetrics. Shall we look off at this also? Congratulations people, you finished the high priority topics. Now what we are looking at, specific terms. What do we mean by specific terms? So in the exam, they will not tell you mechanism of normal labor. If they ask mechanism of normal labor, no, everybody will write. So what they will do, they will give specific terms, and only if you know about the term, you'll be able to write, okay. So that is why we will look at these specific terms also. Naegele's rule. Naegele's rule comes in calculation of estimated date of delivery, right? Look at this, expected date of delivery, yeah. So Naegele's formula is what? Naegele's formula is, you take the LMP, that is the last menstrual period, and to it you add What is this? 9 months plus 7 days. So what is Naegele's rule? Naegele's rule is, let me write it properly here. They didn't write it properly. LMP plus 9 months plus 7 days. This is Naegele's rule. Okay, what is Naegele's rule? LMP plus 9 months plus 7 days is the Naegele's rule. Okay, you got it. Next. Cuvillary uterus, that is blood into uterus, means what? Do you have a photo of that? Do you have a photo for that, people? Yeah, it's loading. Just give it some time. It's so slow. Covulary uterus, severe form of concealed abruptio placentae. Okay, where the blood is entering the uterus. Abruptio placentae. Okay, blood in uterus. Okay, concealed it is. Okay. Okay, done. Then Muller-Munroker means what? Muller-Munroker test means this one, where they are putting the 2 fingers inside and they are checking and they are pushing the head inside, and if the head touches it, that means they know there is no cephalopelvic disproportion. There's a lot of technicality. I'm just telling you overall. Okay. Bishop's score means what? You want to know whether you can induce the labor or not. Okay. So in induction of labor, you have seen all this. Greater than 6, some say greater than 9 is better. That is cervix should be dilated, effaced, and it should be soft. The position, if it is anterior, it's good. Then station of the head should be -1 or 0. So what should be the cervix? Cervix should be dilated at least 3 to 4 centimeters, effaced, consistent, that is soft, consistency should be soft. Position should be anterior, station of the baby's head should be -1 or 0. Then only it is good for induction. That is what is Bishop's score. Very good. Now let's move on. Hagar sign. Hagar sign you will see in pregnant uterus. The fingers will oppose. Look at this image here. It will become clear. Okay. At 6 to 8 weeks, see how the fingers will oppose 6 to 8 weeks. Okay, so this is Hagar sign. Okay. Now let's move on. Where are you? Here. So asynclitism means what? Asynclitism. Yeah, we have a photo for that. See? Asynclitism, engagement of head with asynclitism. The 2 parietal eminences cross the brim one at a time. And then what happens to the sagittal suture? It is not always in line. There is slight tilt. This is called as asynclitism. Some amount of asynclitism is beneficial for the engagement of head. Okay. Now we are going to triple test. Triple test is actually triple marker test. Don't get confused with that breast examination. That is also triple test or something like. This is triple test in obstetrics. Okay. So basically here you are doing the screening for human chorionic gonadotropin, alpha fetoprotein, and estriol, that is estrogen something, right? So basically in neural tube defect, the alpha fetoprotein will be more, right? And in when is HCG more? It is more in Down syndrome. HCG is more, and this estriol is decreased in other conditions. So just remember, if HCG is increased, it can be trisomy 21. If AFP is increased, it can be neural tube defect. Okay. In quadruple, you are adding inhibin. Now let's go to this one, Brand-Andrew technique. This is nothing but control contraction. Look at the textbook here. So here they are doing control contraction. This is modified Brand-Andrew method. Okay. This and all will come in active management of 3rd stage of labor. The body of the uterus is pushed back and upward. The right hand steady tension. Okay. Left hand, where is it? The palmar surface of the fingers of the left hand is placed approximately at the junction of the upper and lower uterine segment. So left hand is outside, right hand is trying to pull. So next is HELP, right? HELP is hemolysis, elevated liver enzymes, and low platelet count. It's a complication of preeclampsia. But I have read that sometimes it can be there even without this, all this. Hemolysis, elevated liver enzymes, and low platelet count. Okay? Say it. It doesn't actually correlate in the head, right? Hemolysis, elevated liver enzymes, and low platelet count. That much if you write, you will get marks. Okay, then coming to APLA, antiphospholipid. Antiphospholipid, what is it? Antiphospholipid antibodies. Wow. Lupus anticoagulant, anticardiolipin, anti-beta glycoprotein. Okay. So for this syndrome, you have to give low dose aspirin or heparin, is it, till 34 weeks. In these people, blood will clot and baby can die. That's why thrombosis can happen. So they're giving a low dose aspirin, heparin for APLA. Next is Bundy ring. Bundy ring. When will it occur? If there is obstruction, it will occur. Okay. So you can see this is a pathological retraction ring. It kind of goes up. It keeps going up and up. Why? Because there is obstruction here. This is pathological. Okay. Bundy ring. Tonic uterine contraction and retraction. Pathological retraction ring. The uterus can rupture, right? So you should do a cesarean section early. Mendelssohn syndrome. What is Mendelssohn? Aspiration during surgery. If she aspirates during surgery. We have our own video on this. Aspiration of gastric contents because of progesterone, etc. Delayed gastric emptying, and this esophageal sphincter also will be relaxed. So aspiration of gastric contents, complication of general anesthesia. So you should always suction. Okay, that's what they are saying. Yay, people, you finished the entire obstetrics, high priority and also specific terms, and we hope you pass. Bye bye.